Diffusion, the international science radio show.
Hello and welcome to Diffusion. Sit back and relax with weird and wonderful science pettifogging your brain. I'm Ian Woolf. This is a special International CFS Awareness Day. Myalgic encephalomyelitis chronic fatigue syndrome. People with CFS can suffer from long COVID-like symptoms such as brain fog, sore throats, headaches, stomach problems, chronic pain, and of course, post-exertional malaise. ME was first described in 1955 after an outbreak of staph at the Royal Free Hospital in London. In Australia, the diagnosis and treatment of CFS is based on the Clinical Guidelines which were last published in 2002. These determine not only how you're treated and diagnosed, but also whether you qualify for the NDIS, the National Disability Insurance Scheme, and the Disability Support Pension. Emerge Australia is an advocacy organisation for the voices of people suffering CFS. Here's Anne Wilson, CEO of Emerge Australia. Hello, Anne.
Come on. Hi. Just Anne Wilson, CEO of Emerge Australia.
Should we start with the clinical guidelines for how to treat CFS and the myalgic encephalitis? So I'm getting it wrong already. Myalgic encephalomyelitis. The draft guidelines came out in 98. And so they haven't been changed in really 24 years, even though it's only 20 years since they were formally adopted. It's a long time for the wrong information.
Yes, it is. But it's the reality is that the clinical guidelines were published in 2002. Nothing has been done, and there's been no update since that time. And, some would argue that there haven't been huge developments happen, but if you speak to our medical director and you speak to a lot of the scientists, there are developments happening all the time. And, what has been absolutely conclusively proven is that two of the elements that are in the old guidelines, graded exercise therapy and cognitive behavioural therapy, do harm. And one does harm because it stigmatizes patients as saying that their condition is psychosomatic, it's not real. The other is just harmful for people who've got CFS. So in 2021, in the UK, NICE actually brought out new guidelines that exclude graded exercise therapy and cognitive behavioural therapy from their guidelines. What's critical is that the inclusion of post-exertional malaise, known as PEM, must be central to the diagnosis of CFS, which it definitely isn't. It's not at the core of the old Australian guidelines and needs to be in future. So, that's what a diagnostic guideline is. It helps guide clinicians to see whether if someone has got PEM and they're able to test for that, then that is a pretty conclusive that's pretty conclusive evidence that a person has got CFS. There are obviously lots of other things that they have to test for, but that needs to be at the core, and it is not at the core of current guidelines. And current guidelines, guidelines need to be outdated as new information and new evidence comes to light. You can't just sit on your laurels and say, 24 years ago we wrote a guideline and that'll be fine. And there's, widespread discussion about the absolute critical need for Australia to have up-to-date clinical guidelines. The problem that we face is that the production of clinical guidelines that are endorsed by the National Health and Medical Research Council cost a lot of money. And there is a process you have to go through that is, it's a good process, includes a thorough a methodological review of all of the evidence. It includes consultation with all stakeholders, and it costs money, a lot of money. And certainly Emerge Australia is pushing forward in, seeking allocations of funding for the production of clinical guidelines for ME/CFS from next year, and it'll take about 2 years to complete the process. So, just because people say, oh, well, why haven't you got a clinical guideline? You just don't write a guideline. A doctor can't say, oh, I'll write a guideline. It's just not possible. They can write a guideline, they can do something for their practice, they can do something for themselves, but something that's going to be accredited and adopted by the various colleges and acceptable to the NHMRC has to follow their processes.
And I guess having that sort of authoritative document is also something that would help if people with ME/CFS need to claim on for Centrelink or for the National Disability Insurance Scheme.
Well, definitely from a diagnostic perspective, yes, because, if you've got guidelines and Emerge Australia are putting together pathways to go onto the desktops of GPs around Australia, if you've got those things in place, it helps that for the GP is then able to do what they have to do, follow the guidelines, follow the processes and protocols, and make a diagnosis. And that's what we want, because without a diagnosis, no one can get anything.
This is the case. And I think it's been a problem. I think we've gone from where GPs used to deny the existence of ME/CFS, and now a lot of them accept it but say, well, I don't know what to do, I'm not an expert. So they really need the education.
Oh, look, and all of that's been fueled by COVID. We've had a lot of criticism over the last 12 months where people have said, oh, you're focusing on COVID. But COVID's been like a magic pill for ME/CFS because it has helped us to shine a light on ME/CFS because of the similarities between long COVID and ME/CFS. Apart from the unique symptoms of long COVID that have to do with cardiovascular and respiratory issues that are quite serious, most of the symptoms that people will experience, you could argue that they are ME/CFS because they're identical. And you get post-exertional malaise, which from Emerge Australia's point of view and the point of view of clinicians around the country is central to a diagnosis. And you'll find that more and more clinicians, when they learn about what to do, will diagnose people with ME/CFS/long COVID because they're really one and the same when it comes to the majority of symptoms.
And would you be able to briefly explain what post-exertional malaise is for the listener?
Yeah, well, post-exertional malaise is when, the smallest little thing completely zaps your energy. Our medical director says, if you go and pick your mail up from your letterbox and you come back and you have to go to bed for 2 days, you've got a problem. Okay, so it's just feeling absolutely exhausted after doing, just minor things. Some people with serious post-exertional malaise, apart from having orthostatic intolerance, where they have difficulty standing up, heart rate goes up, blood pressure goes down, have difficulty just walking to the kitchen or walking to the toilet. Now, in a healthy person, those kinds of activities would not cause the severe reactions that people with ME/CFS get, requiring them to go to bed or lie down for 2 days. So it's exertion, and it's feeling completely exhausted after the mildest of movement or activity.
And then there's the brain fog as well.
Oh, well, this is all part of the cognitive dysfunction that occurs. So brain fog, feeling vague. And one of the things with post-exertional malaise, it's not just physical. So, and I've learned all of this in the last 12 months, but, even concentrating or looking at a computer or being on a phone call is just too much. So it's also cognitive strain, and stress. All of that can cause someone who has got ME/CFS to, to crash. It doesn't necessarily have to be that you've gone to the letterbox to pick your mail up or done some kind of task around the house. It can just be that, it's too much for your mind and your consciousness to cope with. And so I have lots of examples of people who say they can't take a Zoom meeting because, it's too much visually, too busy. It makes them too exhausted. They'd prefer to take a phone call that's an audio call instead. And some people, just have to manage their energy envelope in such a way that they say, sorry, I can only take a couple of calls a week. It's very individual, and it depends on the severity of each individual condition.
Do you think part of the social stigma is also that in society people seem to be used to the idea that you get sick and you recover, or you get sick and you die, and they're not used to the idea that there's some people who just stay sick, and that often disability has to be visible. Either you're in a wheelchair or you're using a cane, and we can see that you're disabled and you need that disabled spot or you need some support. How do we change that?
Well, I think that the definition of disability needs to be redefined. The other thing that needs to be redefined is the definition of impairment. And there needs to be some consideration given to the length of impairment. Not everybody with ME/CFS is going to become bedbound. If ME/CFS is diagnosed early, and if patients learn about pacing early on and how to ensure that they don't exhaust their energy envelope the minute they start feeling better, the faster people try to go out of being sick, the longer it can take for them to, enter into a recovery phase. So all of those things, so, duration, obviously severity, the definition of impairment, the definition of disability, all need to be taken into consideration, as well as the fact that there is this underpinning principle that because ME/CFS is a disease, it falls into the illness category rather than the disability category. And that's why, really both ends need to be redefined in order to ensure that we remove the barriers to entry that are being placed in front of people with ME/CFS. I mean, I've said this many times, and I've borrowed a phrase that I heard someone say a while ago. In what universe is it acceptable for first of all, people with a condition like ME/CFS to be ignored? In what universe is it acceptable that when people are so sick, they go to bed and they stay there for 10 years, and there's no one saying, hello, we need to really do something about this, And I've heard of people who have, waited years to get onto the NDIS, can't get onto the DSP. People are forced to go and pay $3,000 for a functional assessment from an occupational therapist. I mean, who's got that money? Most people with ME/CFS are on the poverty line. So, it's just, sorry.
That's right. Do you need to take a break?
My throat.
Do you need to drink?
No, I'm fine.
Okay.
It'll go away in a minute. Most people with, ME/CFS just haven't got the financial resources to pay for that kind of an assessment privately. Just haven't.
It's just ridiculous. And if you don't get the assessment, I've looked at the NDIS forms. They're really complicated to fill in. They're an enormous bunch of paper for you to go through. So many questions. And if you're not a medical professional, how would you even know what supports are available that you should ask for, because you're not an expert? It doesn't.
Yeah, well, that's the other thing. Yeah, that's the other thing, and that's the other reason why Merge Australia is really pushing for the development of an optimal care pathway, which really is a referral pathway for GPs. So, on the one hand, the cornerstone of our work is GP education, because the GPs need to know how to diagnose ME/CFS. They also need to understand how to distinguish long COVID from ME/CFS and whether, in fact, the person has got one in the same thing. That's critical. But once all of the tests have been done and the examinations have been done, etc., the GP needs to be able to refer the patient on for other assistance. And so a person that has come to the GP that has been feeling dreadful for a very long time, let's take COVID out of the equation for a moment, who thinks they've got ME/CFS or something, they may not even know. Once the doctor is established, because he's gone through our pathway and knows what to do and how to identify ME/CFS, they then can't do an awful lot more, because our health system is divided into consultations that are timed, and it is very difficult, and nor should the GP have to enter into things like sitting down with the patient and helping them fill out an NDIS form. What we need from our GPs is to write that letter that says this is a diagnosis of ME/CFS, and then pass them on to an organisation like Emerge, where we've already got a federally funded case management service run by a clinician who's a nurse. And what we're doing is, developing a multidisciplinary coordinated care service where we will have a social worker and a psychologist and a physiotherapist and an OT on staff. And doctors can then refer via telehealth. It does not need to be done in person. We'll refer patients to us, as we get patients now anyway, who come to our clinical nurse for whatever needs they have. And we would triage those referrals so that the patient gets exactly what they need. So if they need to speak to a social worker to help them fill out an NDIS form, which patients say to us all the time, they just don't have the energy for, their brain fog doesn't allow them to focus, all that kind of stuff. Then they can speak with a social worker and get that underway. Or, the reality is that if you have been, like so many people are, a busy person, you've had a career, or you've been to university, or you were doing year 12 or whatever, and all of a sudden you either get a virus or something happens that leads you to get ME/CFS, your life changes. It's been described by some patients as a living death. And there are issues of grief and loss and mental health issues that people need support in. So people need support from suitably qualified people because their disease has robbed them of so much of their life. It is not because their disease is psychosomatic. It's not the other way around. It's the fact that their disease has robbed them most of their life. And it's not only robbed them. If they're a young person, it's robbed their family of aspirations and dreams of what their child would become. We've had parents contact us to say, we're in our 60s, our 70s, and our child is now 31, been bedridden for 10 years. We have to make arrangements if something happens to us. Where will our child live? Because they can't live in the family home because they can't look after it. What arrangements have to be? But these are dreadful situations for families to have to go through. And to go through that on your own without any allied health support, that's just criminal, really. So people do need support. They do need some form of support in terms of maybe some light physiotherapy under the guidance of a physio that understands ME/CFS. It's not graded exercise therapy, but it's under the auspices of an ME/CFS physio, and we will be doing some training for physios, particularly on ME/CFS in hopefully the second part of the year. Then there's the functional assessment done by an occupational therapist. We'd rather employ the occupational therapist and try to provide those functional assessments without patients having to pay $3,000 a pop, or without government having to employ 20 occupational therapists around the country in clinics that are currently flooded with long COVID patients. And an ME/CFS patient won't even get a look in the door.
And ME/CFS has not been well funded for scientific research ever, has it?
No. Just because $3 million was allocated in 2018-2019 for several projects doesn't mean that the federal government is supporting ME/CFS research. The reality is that we need a major injection. I mean, research costs money, without a doubt. But we need a major injection into ME/CFS research. We just need a major injection into ME/CFS research, support for patients. We need investment, as per our State of the Nation report, into GP education, the creation of an optimal care pathway, the development of clinical guidelines, biomedical research, and then we need the capacity to be able to advocate for changes to the NDIS and the DSP. That's what we need. That's our manifesto for the next 5 years. That's what we're going to be going, and that's what we are going to members of Parliament about now. And we will be continuing our push after the federal election when we know who the new government is.
Is there anything you'd like to add?
No, there is still time. I said no and then I start talking. There is still time for people to hop on our website and go onto the State of the Nation report, which is on our website. And if you click under the report, you have the opportunity to put your details in, and that will bring up your local member of Parliament, customise the letter and press submit, and that will go straight to your member of Parliament. We've already had in excess of, I think, 1,700 people do that. We have 2,500 people in Australia with ME/CFS. We need the voices of people with ME/CFS to be heard, because ME/CFS, people with ME/CFS matter, and their votes will count.
And that was 250,000 people in Australia that are diagnosed with
About
ME/CFS.
1%. It's the same all around the world.
So it's a lot of people, and when the new diagnostic guidelines get in, maybe there'll be more or less, we're not sure.
Yeah, well, a lot of those people, may not be diagnosed. So, but we've got 60% of that 250,000 are either housebound or bedbound.
It's a huge number of people that are getting no support
It's
at
huge.
all, and
It's huge, and it's like, oh, let's just ignore those stats. We won't look at them. It's not a big deal. But you know what? Those are all people, if they're over the age of 18, who have to vote.
well, this is very true.
And there's never been, we're not pushing anything here other than ensuring that the voices of people with ME/CFS are heard. And what we're trying to do at Emerge is make it as easy as possible. We've also got a petition that is going to be put up today on our website as an infographic. It's been running since the commencement of ME/CFS Awareness Week last week. And today is actually ME/CFS Awareness Day globally. And that petition is for the federal government, whoever gets in, to support GP education and patient support services. So necessary. Emerge Australia runs on the smell of an oily rag. We have very few staff. We have a huge agenda, and we need the help of government and funders in order to deliver what we need to for the ME/CFS community.
Terrific. Well, Anne Wilson, thank you very much.
My pleasure.
That was good. And this time I have a recording on several devices. So I'll stop one of the recordings there. I'll just make sure I've got the other one there as well. Yep, that's all good. I'll stop that one. And then I can stop the Zoom.